Okay, let's dive right into this. Welcome to The Explainer. Today, we're not just going to sit here memorizing dry, boring drug lists. No, we are stepping into a high-yield clinical gauntlet to really master infectious disease management. We're going to completely filter out the clinical noise and rely entirely on first principle mechanics to outsmart some of the most critical pathogens you'll ever encounter. Sound good? Let's get started.
So, here is our game plan. We've got 4 strategic modules to conquer today. The peptidoglycan shield, the Pseudomonas empire, central nervous system crisis, and we'll wrap it all up with a mandatory validation drill.
All right, Module 1, the peptidoglycan shield. Let's look at gram-positive resistant vectors.
Let's set up our very first battlegrounds by putting MRSA and VRE head-to-head. Now, for gram-positive bacteria, the core first principle concept of resistance is all about altering their target binding site structures. In a real clinical scenario, you really have to filter out what we call step 2 noise, things like a patient's remote history of mild penicillin nausea. You've got to ignore that noise and focus strictly on the genetics. Take MRSA, for instance. The genetic driver there is the MECA gene. It literally causes a structural shift from a standard penicillin-binding protein to PBP2A, and that creates this incredibly low affinity for almost all beta-lactams. VRE, on the other hand, uses the VAN-A gene cluster to do something wild. It literally swaps out its terminal amino acids. It changes diala-diala to diala-dilac. It's just a brilliant microscopic evasion tactic.
Now, when we're confronting these systemic MRSA or VRE infections, we often deploy daptomycin. This is a highly potent lipopeptide antimicrobial. It works by inserting these lipophilic teals directly into the bacterial membrane, which causes rapid fatal depolarization of the cell. It's an absolutely incredible, powerful agent for things like skin and soft tissue infections or right-sided endocarditis.
But wait, there is a massive fatal flaw you absolutely must remember here. Daptomycin is completely denatured and inactivated by pulmonary surfactant. Think about that for a second. If you have a patient with MRSA pneumonia and you reach for daptomycin, you are essentially just pumping them full of expensive water. It must never, ever be used in the lungs.
Okay, moving right along to Module 2, the Pseudomonas empire, focusing on gram-negative coverage.
With gram-negatives, the rules of resistance totally shift. Instead of just tweaking binding sites, these pathogens build up these formidable outer membrane permeability barriers, and they aggressively upregulate efflux pumps to literally spit our antibiotics right back out. To manage this, we escalate empiric therapy using a severity invasiveness scale. So let's say you have a stable patient with a soft tissue infection, right? Narrow-spectrum agents like cephalexin are totally fine, but step 2 is emergent. Neutropenic fever with an absolute neutrophil count below 500. This is a medical emergency demanding immediate monotherapy anti-pseudomonal coverage, like cefepime or piperacillin tazobactam. Cross into critical territory, we're talking septic shock with suspected multi-drug resistance, and there is no time to mess around. You must hit them with double anti-pseudomonal coverage immediately.
All right, Module 3 takes us to the brain, central nervous system crisis, and the meningitis fork.
In a suspected bacterial meningitis crisis, the absolute core concept is blood-brain barrier penetration kinetics. Your timing and the exact sequence of your interventions will literally dictate survival. We have to follow a strict chronological map. At minute 0, your absolute first priority is a triage check for signs of elevated intracranial pressure, stuff like papilledema or focal neurologic deficits. If you see those, stop. Do not send them straight to a lumbar puncture. By minute 5, you start empiric antibiotics and dexamethasone. Then you secure a head CT by minute 45 to rule out a mass effect. And only if that CT is clear do you actually proceed to the lumbar puncture at minute 90. Now, take a close look at the imaging we've got on the screen right here. You can clearly see a ring-enhancing lesion with a low-density core, and it is causing a very dangerous mass effect. If you had missed the focal deficits during triage and blindly performed a lumbar puncture on this patient, well, the sudden drop in spinal pressure could literally cause the brain to herniate downward through the foramen magnum. It's a fatal error. So remember, antibiotics first, CT second, LP last in these high-risk patients. And when we say empiric antibiotics for meningitis, we have to be incredibly specific. For adults under 50, the gold standard is ceftriaxone, that covers S. pneumoniae and N. meningitis, plus vancomycin for highly resistant pneumococcal strains. But, and this is crucial, pay close attention to the age-based add-on. For adults over 50 or anyone who is immunocompromised, you are medically obligated to add ampicillin. Why? To empirically cover Listeria monocytogenes. Okay, home stretch. Module 4, the mandatory validation drill. Let's synthesize and apply everything we've just learned.
I'm going to present 2 high-stakes clinical vignettes to you. Let's see if you can spot the errors. Here's vignette 1. We've got a 68-year-old male admitted with a severe right lower lobe lung infiltrate on his chest x-ray. His blood cultures come back positive for methicillin-resistant Staphylococcus aureus. The treating physician immediately initiates an intravenous lipopeptide antimicrobial that punctures bacterial membranes via calcium-dependent insertion. So, what is the critical error here?
Did you catch it? The physician essentially prescribed daptomycin. Now sure, it perfectly matches the description of a membrane-puncturing lipopeptide that covers MRSA, but we are dealing with a severe lung infiltrate. As we established earlier, daptomycin is immediately denatured by pulmonary surfactant. Remember the expensive water analogy? The correct solution here is to use vancomycin or linezolid, since those maintain high efficacy right there in the lung tissue. Let's move on to vignette 2. We have a 32-year-old female receiving chemotherapy for acute myeloid leukemia, and she develops a fever of 102.4 degrees Fahrenheit. Her absolute neutrophil count is dangerously low, sitting at just 150. Now, she's hemodynamically stable, but her chart notes a true, documented anaphylactic reaction to penicillin. Based on our severity invasiveness scale, what exactly must you do next?
And this right here brilliantly illustrates how we combine our frameworks in action. The triage step tells us this is an emergent neutropenic fever because her ANC is way below 500. Next, the target dictates that anti-pseudomonal coverage is absolutely mandatory. But we have a major constraint, true penicillin anaphylaxis, which means our standard go-to agents carry way too high of a cross-reactivity risk. Therefore, the exact next step is initiating a regimen like vancomycin combined with aztreonam. Aztreonam is a monobactam that safely provides robust anti-pseudomonal coverage, even in our penicillin-allergic patients.
Well, there you have it. You've successfully navigated the clinical gauntlet, mastering the nuances of pathogen mechanics and targeted therapies. But before we wrap up, I want to leave you with one final sobering thought. These pathogens are constantly rewriting their own genetic code, shifting their PBPs, and building better, faster efflux pumps. As antimicrobial resistance evolves faster than our own drug development pipelines can keep up, how will our current first-principle strategies actually hold up against the next generation of superbugs? Keep learning, keep questioning, and I'll see you in the next explainer.